Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about lymphoma with Dr. Scott Huntington. Dr. Huntington is an associate professor of medicine and hematology at the Yale School of Medicine. Here's Dr. Weiner.
I want to spend the first half of this time, at least that, talking a little bit about your area of clinical interest, which is the treatment of individuals who have lymphoma. Can you just tell us a little bit about what lymphomas are, how common they are, and maybe a little bit about how variable they are?
Sure. So lymphoma is a really diverse set of blood cancers. As a group, it's the most common type of blood cancer. And so non-Hodgkin lymphoma in particular is the seventh most common cancer here in the United States. But non-Hodgkin lymphomas is not just one disease. In fact, there's over 70 different types of non-Hodgkin lymphomas, and they range in clinical presentation, and they range in how we actually manage these diseases. And so non-Hodgkin lymphoma can be either slow-growing or indolent, and a patient might have that condition for years before it's brought to attention or identified and diagnosed. Conversely, there's lymphomas that progress and cause symptoms within days to weeks, and those really require urgent evaluation and treatment. There's also Hodgkin lymphoma. So Hodgkin lymphoma is a separate type of lymphoma. Only about 10,000 cases of Hodgkin lymphoma per year in the United States. That cancer has two real patient populations that we usually see it in. Those that are on the younger side, so teenage or early 20s. And then there's another, what we call bimodal distribution, closer to the 60s and 70s. So when we think about lymphoma, it is a really diverse group of patients, all ages, all different presentations, and really the way that we approach lymphomas can vary dramatically from each individual patient.
And from my perspective as a non-lymphoma medical oncologist, I typically think of lymphomas as being divided into at least two big groups. A group of lymphomas that tend to be relatively slow-growing. Oftentimes, these are the patients who may have had the problem for quite some time before they come to medical attention, and then the rapidly growing lymphomas. Is that a fair characterization?
It is. And within, let's say, non-Hodgkin lymphoma, we have B-cell non-Hodgkin lymphoma, which about 85% of non-Hodgkin lymphomas fall into B-cell, and the remaining 15 are T-cell. And within those, there are, like you said, these slow-growing lymphomas that often are lingering for years before it's either identified on routine blood work or imaging that's done for another condition. So we call that incidental identification of an asymptomatic lymphoma. Conversely, there's both B and T cell non-Hodgkin lymphomas that present very symptomatic, rapidly growing. And for those that have rapidly growing lymphoma, it's really key to render a diagnosis urgently and get patients seen by a lymphoma specialist so that we can start systemic therapy. We actually often cure those aggressive lymphomas if we catch them and treat them aggressively. Conversely, the indolent or slow-growing lymphomas may not need treatment. Sometimes patients do very, very well with after surveillance and may never need treatment for their indolent non-Hodgkin lymphoma. Others, their non-Hodgkin lymphoma will progress to the point where it might cause symptoms, and we can effectively treat those patients and often get patients into remission and back to their great quality of life.
Got it. Since you brought this up, what's a B cell and what's a T cell?
Yeah, so lymphomas are derived from lymphocytes. So our immune system has lymphocytes. B cells typically are the lymphocytes that are helping make antibodies to reduce the risk of subsequent infections. T cells also are important with eradication of infections, often viral-mediated infections. And our immune system can, get a genetic disturbance that leads these cells to survive where they're supposed to basically succumb. And over time, these cells can proliferate and become cancers. I often will tell patients, particularly indolent lymphomas, that it's a disease of accumulation. These lymphocytes that are cancers are not particularly, aggressive or causing harm, but they're accumulating when they're not supposed to. They're either accumulating in lymph nodes, so patients might have swelling in the lymph nodes or masses in organs, or they might have their bone marrow effectively be crowded out by these lymphocytes that are accumulating, and that's what leads to patients becoming symptomatic.
So maybe in the simplest terms, a B cell could develop a mutation, a genetic change that allows it to replicate and avoid the normal aging process. So it doesn't die on its own, and these cells just continue to grow and proliferate. Is that right?
That's correct.
Got it. So how do you usually diagnose lymphomas? I know that patients can come in with symptoms. Patients can come in with enlarged lymph nodes. They can come in with a variety of other difficulties.
Yeah, so just like the disease itself being 70 or 80 different types, the presentations can be incredibly diverse. So like you mentioned, for the slow-growing lymphomas, they often are found by primary care doctors. Patients might have routine blood work that over time might show a elevation in their white cell count or lymphocyte count in their blood, or they might come to the emergency room for, let's say, appendicitis or other condition, and a CT scan not only shows that condition, but also shows some enlarged lymph nodes. That could lead to a biopsy, which ultimately could render the lymphoma diagnosis. Conversely, there's some patients that really present with symptoms. And what are these symptoms? They might be often painless swelling in the lymph nodes in the neck or the underarms or the groin region. It could be what we call constitutional symptoms, so things like fever, chills, drenching night sweats, low appetite, weight loss. Really, patients presenting with that condition will often then lead to a CT scan or other imaging modalities that could then identify a mass or a lymph node that's enlarged. Ultimately, the diagnosis of lymphoma often comes from either blood work in rare instances, but more commonly requiring a biopsy. Ideally, we would take a lymph node out and we can really look under the microscope at the entire lymph node architecture to help make this diagnosis. Other times, a small needle biopsy will be enough for us to make the diagnosis of lymphoma.
And the treatment has changed a fair amount over the years?
It has. I think as a medical oncologist, lymphoma has been an area of success for many decades. So when we think back into the 1970s or 80s, lymphoma was one condition where, particularly Hodgkin lymphoma, we had success curing patients with advanced stage with traditional chemotherapy combinations. In recent years, we've really shifted away from often using chemotherapy as we learn more about the kind of genetic underpinnings and really the drivers of lymphoma. We're now incorporating more targeted therapies, tailored treatments, often orally administered, that either help chemotherapy work better or perhaps even work better, that not needing chemotherapy itself for many of our particularly indolent lymphomas like CLL, chronic lymphocytic leukemia. For those patients that have more resistant lymphomas, we now even have immunotherapy, where we take a patient's own immune cells and can actually engineer them to go after a target protein on the lymphoma cell. We call that chimeric antigen receptor T cell therapy, and this is a therapeutic modality that's increasingly used to treat the most kind of difficult to treat or resistant lymphomas.
People may know that as CAR T cell therapy.
That's correct. So CAR T cell therapy is a really exciting field, and hopefully with time, we'll have other uses outside of lymphoma, including things like solid tumors.
And does anyone with lymphoma still get treated with just chemotherapy?
Yeah, particularly the T cell non-Hodgkin lymphomas, we have less kind of targeted treatments for that. Why is that? T cell lymphoma is relatively uncommon, it's rare, and it's a really heterogeneous group of malignancies. And so we have a lot of work to better refine our management for T cell lymphomas. And so some instances, traditional chemotherapy works quite well, and we're still using that. For B cell lymphomas in particular, we often have a chemotherapy backbone with either a targeted immunotherapy or antibody therapy, or oftentimes a targeted oral administered agent.
And when we talk about CAR T cell therapy, is that therapy that is now replacing bone marrow transplant, which formerly was done for lymphoma, or are we still using both of them?
We're still using both. It really depends on what type of lymphoma the patient has and when they're presenting with the difficult to treat lymphomas. I think the greatest need of using CAR T therapy is when we have a lymphoma where we give therapy that should work or is predicted to work, and there really is not a response early on. So we'll call that primary refractory lymphoma. And those are the lymphomas where, giving additional chemotherapy, which is effectively what we ought to do in an autologous stem cell transplant, is unlikely to be effective. And so switching the modality to cellular therapy, CAR T therapy, is really important in those patients. And so for the most common of the non-Hodgkin lymphoma called diffuse large B-cell lymphoma, CAR T is approved for some patients in the second-line setting immediately following traditional chemotherapy.
So if we're educating the cells to go after the lymphoma cells, it's sort of functioning like a smart bomb.
It is, and it is smart, but it is notable that these CAR T cells, they target a protein that's also on normal B cells. And so
I was going to bring that up.
Yeah. So, our therapy is smarter. It's still not perfected. And so there are complications from CAR T, and in particular, getting rid of someone's immune system, reducing their ability to fight infections, often viral infections. And so there is, long-term follow-up and additional kind of supportive care that's needed alongside CAR T. And that is one of the reasons why for patients that their lymphoma is responding to traditional treatment, we really forego CAR T or a lot of other immunotherapy. But for those patients where our traditional standard therapies aren't working, this is a really important advancement for those patients.
So for the patients who have more rapidly growing lymphomas, the ones who for years we've been able to cure some, but not cure everyone, with these new therapies, is the proportion of individuals who are able to be cured going up?
It is. We're still working on improving that initial therapy, right? So there's been incremental advances in incorporating novel either immunotherapies or what we call antibody drug conjugates, so kind of more smart chemotherapy into the first line setting. Ideally, we will cure patients with 4 to 6 months of treatment and never have to deal with lymphoma again. CAR T is really a backup strategy, and it's good to have that backup strategy. And so really the clinical trial development is both on the first line setting, that's cure more people, minimize relapse, but at the same time, for patients that are not cured, having a better backup strategy with CAR T is really important.
So we're going to take a break for just a minute. When we come back, we'll talk about some of the survivorship issues that exist for people who have lymphomas, some of the problems that they can run into after treatment has ended. And then we're also going to talk about healthcare delivery that is not just about lymphoma, but about cancer care in general.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their endocrine cancers program is one of the largest multidisciplinary programs in the country and is experienced in treating rare cancers. More at smilowcancerhospital.org. The American Cancer Society estimates that over 200,000 cases of melanoma will be diagnosed in the United States this year, with over 1,000 patients in Connecticut alone. While melanoma accounts for only about 1% of skin cancer cases, it causes the most skin cancer deaths, but when detected early, it is easily treated and highly curable. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital, to test innovative new treatments for melanoma. The goal of the Specialized Programs of Research Excellence in Skin Cancer grant is to better understand the biology of skin cancer with a focus on discovering targets that will lead to improved diagnosis and treatment. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Hello again. This is Eric Weiner here for the second half of Yale Cancer Answers. I'm here with my guest, Scott Huntington, a lymphoma expert at Yale Cancer Center and Smilow Cancer Hospital. Scott is also our Chief Quality Officer at Smilow Cancer Hospital, and we'll be touching on issues related to the quality of cancer care delivered in just a few minutes. But first, I said that we would talk a little bit about survivorship issues. So cancer treatment's done. Scott, imagine you have a patient who had an aggressive lymphoma. They have gone into remission. You hope that they are never going to have another problem related to the cancer itself. But what kind of problems can people run into in terms of late effects of lymphoma treatment?
That's a great question. Survivorship is incredibly important in lymphoma care. As we are improving our care, we're curing more patients, and we need to recognize that maintaining their health outside of lymphoma, outside of their cancer, is really important. So the effects that we see long term from the actual treatment have reduced over time. Our therapies are more tailored in terms of, say, reducing radiation exposure, reducing the cycles of therapy, but we still have to look out for changing in blood work. So occasionally patients can have increased risk of dysplasia of their bone marrow following chemotherapy. If patients have radiation, there may be post-radiation specific follow-up, including imaging follow-up perhaps. But it's important to note that patients with particularly non-Hodgkin lymphoma as well as Hodgkin have increased risk of other cancers. So part of my education of patients, when they're 4 or 5 years out from their cancer, is really transitioning away from this idea of having lymphoma follow-up, but really making sure that they're having routine health care, that they're working on cardiac, reducing their cardiovascular risk, but also staying up to date on other age-appropriate cancer screening. Usually, once a patient's 5 years out, and particularly with those aggressive lymphomas treated with curative intent, I'll transition those patients to their primary care doctor with the focus of really maintaining kind of long-term age-appropriate cancer screening.
Well, that's really, really critical. Maybe we can move on now and talk about the delivery of cancer care. And we'll touch on a number of different areas. Maybe first we can talk about guidelines and the use of cancer care guidelines. And first, what cancer guidelines are, and second, how you think that they should be used.
Yeah, it's a good question. So cancer guidelines, or guidelines in general, ideally are informed from data, from either randomized trials or meta-analyses of multiple trials. But many of our clinical decisions that we have in oncology and medicine more broadly lack the clear data, randomized data. And in that situation, we often look to experts, clinical consensus experts. And we have that in oncology with NCCN, but also even
what is the NCCN?
The National Comprehensive Cancer Network, or NCCN, and Yale is one of institutions. And so we meet as a committee, as a group, and review the data. And where data is clear, there's consensus, and where the data is not clear, then it's really focused on kind of identifying what is the typical approach, and if we have data to suggest that is really the optimal approach, getting those guidelines to our clinicians to make sure that they're offering modern and kind of up-to-date cancer delivery is really important.
And there are many situations where it's been shown that giving care that is concordant or in keeping with guidelines is better than just having physicians make decisions entirely on their own without paying attention to guidelines.
Absolutely, and it also, may actually reduce the cost of care. So if there's less variations, you can really standardize both the follow-up, standardize the diagnostic evaluation. So are patients having appropriate testing, whether it be molecular testing or imaging testing? Guidelines are not only in the treatment, but really can be across the continuity and continuum of cancer care, from diagnosis all the way to long-term survivorship.
But one of the things that I've often been challenged with is that guidelines will speak to how one should treat the average or typical patient. And sometimes patients don't fit into that category. Patients may have other medical illnesses. They may have a unique set of preferences in terms of what treatments they're willing or not willing to consider. And how do you blend guidelines with the needs of individuals and differences from one individual to another?
That's a really great question. I think one is how the guidelines are developed and really delivered to clinicians, right? So I think guidelines need to be explicit that this is not a one-size-fits-all, that absolutely patient preferences need to be valued, and recognizing that guidelines really can't cover every clinical scenario or question. I think guidelines are important to kind of establish, like you said, the average. On average, we hope that these patients would be receiving this care, but it's really important to note that there are patients that these guidelines do not fully address or influence their management.
Yeah, so do you think it's fair to say that we probably shouldn't be practicing what I'm going to call creative oncology, or coming up with a unique plan for every patient, that doesn't make sense? On the other hand, we probably do need to take guidelines and, with some frequency, not necessarily all of the time, adjust them to meet the needs, both physical and psychological and other sorts of needs that an individual patient may have.
Absolutely. And I also think guidelines might have more influence or more importance depending on where you are in your career, and also what your focus is. I only see patients with lymphoma. And so while guidelines I think are important, particularly when I'm talking to trainees or residents about approaching lymphoma, my expertise and experience may not require as much focus on guidelines versus a clinician that's busy, that sees lots of malignancies, or advanced practitioners that have to see lots of patients. Those guidelines really provide a base. And here at Yale, we do use pathways or guidelines for treatment, but we recognize that 100% compliance on pathway really would not be ideal. And in fact, we expect a fair amount below that 100% guideline concordance is kind of optimal.
And I guess I'd say that the other very important part of taking care of a patient is spending time talking about the care you're providing with your knowledgeable colleagues. And I think that patients in general should expect that their doctors are not functioning as entirely independent practitioners, but they're really working within a group so that they have a chance to bounce ideas off one another.
Absolutely. And certainly with lymphoma, the first step is really engaging with our hematopathologist to make sure that that there's real consensus on the diagnosis. More than 70 different types of non-Hodgkin lymphomas. Which subtype does this patient have? And then we often will have multidisciplinary meetings with radiation doctors and radiologists, as well as lymphoma clinicians, to really make sure that we're all in agreement and moving forward with the optimal care.
And how did you get interested in what is often called cancer care delivery, or in health services research, that is research that is focused on how we actually practice medicine, how we deliver care. What got you excited about that area?
Yeah, it was really during my first year of training in oncology. I trained at a facility that was really developing CAR T at the time. CAR T worldwide was only being delivered at just a handful. And I saw firsthand at how amazing these therapies could be, but I also recognized the tremendous amount of resources and complexity that really was required to deliver this treatment. And so, recognizing that a large swath of the world, and even here in the United States, may not have access to a highly academic, highly resourced academic medical center, maybe think about what are the other kind of modern cancer treatments that may not be able to be delivered as equitable, and that was really shifted my focus away from, say, seeing patients and developing drugs to really focusing on when we have a therapy or a diagnostic tool that's been approved and shown to be beneficial in patients on clinical trials. How do we make sure that translates into improved outcomes and kind of routine care and at the population level? And so that's really why I've focused in the last decade at ensuring, the treatments that we have approved can really be delivered in the patients at greatest risk and greatest need are getting access to these therapies.
And when you look ahead, what do you think the advances will be in terms of cancer care delivery? Are we going to be giving more therapy at home? Is it really going to happen that we'll be giving chemotherapy at home? What other changes do you imagine will take place in the next, 5 to 10 years?
Yeah, it's a good question. I think the first thing to recognize is just the amount of information, amount of data that is going in front of patients and their clinicians or their clinical teams. And my hope is that our kind of interface with electronic healthcare records improve, they become smarter, and we're able to really identify kind of trends or key insights from data, rich data that's put in our electronic healthcare record. And that really allows patients to have and physicians to really identify and personalize their treatment. Perhaps guidelines can interface more clearly with patients and providers. So that's kind of first step to really select the right patient or right treatment for the right patient. Once a patient is receiving therapy, I think the next phase of kind of healthcare delivery is really to engage the patients more continuously. Do patients provide constant feedback through their smartphone or through portals? Do patients start wearing wearables? So we understand what their temperature is or how many steps they're putting in, really to identify patients that might be having more side effects or toxicities from our treatment. And then once a complication does occur, how can we keep patients out of the hospital and home? And that might be with things like hospital at home. At Yale, we've started working on hospital at home. And I do think that modern cancer care delivery is going to use technology. We're going to have more healthcare technology to really enable patients and their families to be more engaged in their care, but also healthcare practitioners and their teams be able to really enable more efficient, more patient-centered, and really overall higher quality care.
Dr. Scott Huntington is an associate professor of medicine and hematology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.